Okay, so good evening, good morning, good afternoon, wherever you are. Thank you for joining us in this wonderful event. I'm more than excited for this session, actually. I'm Mariam Bakhtiari. I'm a recently graduated pediatrician from Tehran University of Medical Sciences, and I have the honor to welcome you guys to the last day of the 33rd International Congress on Pediatrics held by Tehran University of Medical Sciences. So our session today is going to be about the pediatric ICU managements and different topics that our dear Professor Deep has arranged for us, and we cannot wait to listen and to learn. So I just want to mention a few points and notes for our audiences. Please keep your microphones muted during the lectures and also the videos stopped during the lectures, and you can use the chat section to write down your comments, insights, or any questions that you have, and we will ask the questions from our lecturers after each lecturer speak, or maybe at the end of the session. We will see how we'll go. Please make sure to use your actual names as your user ID here, because that is the name that is going to appear on your certificate of attendance. And I have to mention this, that if you want to receive the certificate of attendance, you should register via our website that we will provide, and we will also repeat in our chat section. So you should register on our website and reserve a seat on the desired session that you want to receive certificate of attendance. For our Iranian audience who want to receive CME credit for this session, don't forget to participate in the exam that is provided on the website ircme.ir after this session is over. And this session is being lively broadcast on our YouTube channel, Tom's Pediatric Webinars, and it can be accessed there after this session is over as well. So with this introduction, first of all, I want to start this session with a video clip of introduction of our dear lecturers. So dear Mahia, if you can. Okay, thank you, dear Mahia, for sharing our introduction video. I welcome again whoever has joined us again, and this is my honor to be here actually. And I want to thank again dear Professor Deep for arranging this session, and also dear Dr. Gharib for also inviting all of these amazing lecturers. And I can't wait to listen. So I'm gonna start our session with our first speaker. So our first speaker is going to be dear Dr. Philip Knight. So he's a consultant in pediatric critical care at King's College Hospital, London, and a pediatric critical care transport for the Children's Acute Transport Service at Great Ormond Street Hospital since the beginning of 2020. He did his pediatric critical care grid training in Bristol and completed a pediatric critical care fellowship in Vancouver in 2018. He has interests in transport medicine, electronic patient data, as well as quality improvement, neurocritical care, and status epilepticus. With this introduction, dear Dr. Knight, thank you for joining us, and we can't wait to listen to your lecture about the transport of a critically ill patient.
Wow, what a warm welcome. Thank you so much. Thank you so much for inviting us to speak today. I'll just bring up my slides. You can see them okay?
Yes, they are perfect.
Great. So this section is going to be focusing on children's critical care transport. So we'll jump straight into it. I'm Phil Knight from CATS, which is based in North London out of Great Ormond Street. And I also do clinical shifts on the PICU at King's. So I'm going to try and use a clinical example that would use with the trainees to try and bring out some practical advice that we can give you, some of the logistical decision makings that will be local to our service, and then for those that are already doing a lot of transport, some of the bigger picture stuff that we can collect prospectively and that we're excited about. So as I mentioned, I work at CATS, which is North London. So that was an amalgamation of 3 transport groups that were working out of ICUs. And so we're now standalone, although we're based around the corner from Great Ormond Street. We just do transport there, and we supply 5 PICUs with patients, 4 in central London. And just to note, that will be relevant to our case, that not all of the ICUs do cardiac services, not all of them do neurosurgical input on site. And so that plays in a lot to our logistical decision making. And we're the busiest in the UK, receiving 2,500 referrals per year. And about half of those get converted into transport. So a lot of our work is actually advice and the stabilization, and we welcome that. And we've got one number that you dial into for that. We're commissioned for specialist services, so children that are going to be referred for ECMO, liver failure into King's, and vein of Galen into Great Ormond Street. And so just as a side note, we find in the office there the conferencing calls that we can do through our own administration super valuable in these very sick patients, or those where there's multiple specialties involved. And to note that our local teams are responsible for doing their ward transfers and time critical transfers, which again might play into our example. Just to give you a bit of an idea of the landscape, so this is the sort of borders of the different transport teams in the UK. And so this is our grey area here, London being the most populous, and we're based in North London. But each of these areas is a sort of 3 to 4 hour drive time, which is deliberate. So the majority of our transports are land-based, and then we do helicopter transfers for those that are further afield. So road-based is the majority of our work. And this is zooming in into North London. So this will be 17 of our local hospitals that we cover. This is inside the M25, the circular road around London. So this takes about an hour to get to on blue lights, longer if you were driving in regular rush hour traffic, not in an ambulance. And so we're based here with the local stars, and that's where the Queen lives, just around the corner. And all our ICUs are in a very short distance. Just to note, check out our website. We're going to use a very brief clinical example, but we've got educational videos that are free that go into sort of disease processes, so cardiac, neurosurgical. So our guidelines are on there as well. We'll jump straight into the case. So this is really to highlight what we would go through, because of our trainees are all different backgrounds: pediatrics, anesthetics, and nurse specialists. That a neonatal collapse is a good example. So we're going to use a 3-week-old baby. This actually happened at the beginning of the sort of pandemic, 4 kilos previously, well, that presented to emergency department off their feeds and floppy. They were poorly perfused and arrested during a cannulation attempt, but post-arrest were vigorous and posturing. And so the trainee that called up wasn't actually part of that initial assessment. So that might be a spare member of staff that was called at different times. So sometimes we get a perfectly sort of packaged patient that we're asked to transfer, and then others they've called very early on because they know that this is escalating, which again we welcome, but we need to make sure that we're talking to the right people and that we're getting the right information, because their follow-up questions are often, when are you coming? Have you left yet? And are you almost here? But actually, for this example, our teams were out. And so we need to do some decision making. Is it going to be a time critical transport the local team's going to have to do? Do we need to divert one of our teams? And then there's sort of a couple of hours there we can do some sort of concise investigation and guidance. So for our trainees, so particularly anaesthetists that would tend to be less familiar with the pediatric side of things, that their age is a red flag, and this would fall into neonatal collapse territory. They'd offered already a heart rate of 220, and for me, that always leaps out that could this be an SVT? So we're starting to pick up valuable information even in just the first few lines that they've given us, and there's some neurological concerns. So our status is that both our teams are out. We have 3 teams 24/7 in the winter, 2 in less busy times. And as you saw, the geographical teams that we can rely on to help out are actually quite far. So we need to be quite concise in the advice that we're giving. This is a busy slide, but it's to highlight that this is taken from actually the South Thames guidance, because they've got nice differential boxes and the things that we're going to be focusing on. And we're going to apply this to the case to see how we can best guide them so that we're not getting them to do extra things, taking up lines with infusions that they don't need. So sepsis needs to be at the forefront of our mind. Cardiac is probably the next most common as a large group, and trainees will often sort of throw out, oh, it could be a duct-dependent lesion or a specific thing, but actually we want them to take a step back and think of these as, could it be pump failure? Could it be an arrhythmia? And then splitting your congenital conditions into duct-dependent systemic problems versus pulmonary problems, and then non-duct dependent. And how can we tease that out using the information that they give us? Metabolic conditions, they're also usually less familiar with, but needs to be thought of early so that we can get the blood test back. And they split theirs next into trauma, but we need to think of it as a neurosurgical problem versus an acute abdomen. So it's not necessarily always trauma. Those things would be the only change I would make to that. So we need to be thinking, as we're asking our questions, what is our differential diagnosis? What's the response to the treatment that they've already given? What team are we going to use, and where are we going to take them? As we mentioned, the ICUs don't all offer the same services. And so thinking of neurosurgical emergencies, we've now got someone that was actually examining the patient. So we've got accurate information. They describe the fontanelle as full but normal. The pupils are equal and reactive, and there's no evidence of trauma, but there is some posturing. So this child is going to need a CT, but it feels a little less likely that this is going to be a time-critical neurosurgical emergency. The work of breathing has become severe, and they've mentioned good saturations, but we want to know, are they reaching 100% saturations? Could this still be a duct-dependent lesion? And for this patient, they were achieving 100% saturations. They weren't particularly acidotic. And then on direct questioning, their heart rate post-arrest is actually 160. The P waves are visible. Their femoral pulses, again, thinking about your duct-dependent lesion, are easily palpable. But there's some markers that potentially there could be a cardiomyopathy going on with a very easily large palpable liver. We want to know the response to that fluid, which we'll get to, but the abdomen appears normal. The ammonia wouldn't have come back straight away, but of note is normal for a neonate, and anything above 150 we would certainly want to repeat, but it doesn't seem like this is a metabolic condition as we're going through. So we would, or I did for this case, divert our team that had just dropped off at a local ICU and did a back-to-back retrieval. So it looks like this child is certainly escalating and they'll need our support, and there's not one for the local team. So we'd always advise that you keep snacks and water on you, because in busy times, back-to-back retrievals are fairly frequent. So they plan to intubate this patient, which we'll talk about the planning around that, but what we'll play into that is the response to that fluid. So it seemed that there wasn't a huge amount of benefit with that fluid, and if anything, their work of breathing has become worse, and they've got an easily palpable liver. They've gathered access quickly, which we advocate for IOs and anyone that's struggling to get IV access in, and they're going to cover for infection. On neurology, we're going to get a CT head, which turned out to be normal. You'll miss things if you just do a cranial ultrasound, but it is reassuring to rule out those significant bleeds if you can have a quick look. And cardiac, we'll show you the x-ray, but it was described to me probably secondhand as nil focal, but we'll see that actually direct questioning would have revealed a bit more. So it doesn't seem from our direct questioning that this child is likely to need prostin, but if there was persistent ongoing perfusion problems, then it's potentially something we could add in. And metabolic, although we've got some persistent acidosis and lactate, it doesn't feel like that's the problem. Probably a main piece of advice that I want to give is that we should embrace our checklist and intubation checklist particularly. I think those, if you've got an ICU background, I won't go through all the aspects of it, but particular to us giving advice over the phone and our teams when we're there, optimizing the patient is so important, pre-giving those induction drugs, what those induction drugs are. So it's still not unheard of for people that if they're in septic shock to receive a regular dose of propofol, and this is just not a cardiovascularly stable approach. So we would use ketamine with the extra symptomatic effects as a drug of choice for compromised children. Even then, normal doses can cause compromise. So you need to preempt hypotension. Do they need optimizing? And this child, I wouldn't give a fluid for fluid bolus, but I would have adrenaline attached and ready to go. And we need to be specific about our advice. As if we say, oh, you should consider it, have it around, then it tends to be too far away to be used in an emergency. And the others is really focusing on basics. We see time and again problems with tube size, position. So have that ongoing monitoring with the CO2, get the chest X-ray and sedation and paralysis to keep our tubes safe. This is just pulling back a little bit, and what we do at the moment, we prospectively collect emergency intubation data. So it takes a few extra minutes for the trainees to collect when they're out. But just using the question of how often do we use the wrong size tube? How often do we make changes to the tube? And the answer is quite frequent. So we want to be able to help those sort of 17 local hospitals improve. And a way of doing that is finding metrics where we can report back to them how they're doing on specific things. And that helps engagement. So this was more of a traditional audit that took 6 months, but now with electronic data entry, we can retrieve this actually very quickly. And so for those of interest, that is something that we find very useful. So in a lot of our cases, the work is done when we arrive. The things I wanted to highlight that I think are very useful is that after we've taken a handover, we make up an airway bag, which for us is a roll with everything you'll need to re-intubate or cope with respiratory problems. And so that really puts your mindset that that could occur and that you're ready to go. You've sized your equipment and you've got it to hand. This child will be transferred on high ventilation and oxygen pressures. The perfusion was a lot better, lactate was down, ECG reported as normal, but I'll show you that as well. A very quick note on lung ultrasound, although it's not available everywhere to everyone, it takes seconds on ultrasound to rule out something like a pneumothorax. So I would really recommend getting a basic level of understanding of that. And echoes by non-cardiologists can be misleading, but in this case was helpful. And then so prior to the transfer, once we're on our equipment, all cases get discussed with a consultant. And again, I'd really want to highlight the importance of thinking ahead to what could happen in the back of the ambulance, which is traditionally desaturation problems, hypertension problems, or disease specific. So for this case, I think we've got a preceding high heart rate of 220. We've got evidence of cardiac failure, that having adenosine all drawn up, ready to go. These things are important to think of ahead of time. 3% saline neurosurgical emergencies. The dopes there is for your dislodged, obstructed pneumothorax or equipment failure that people often use as an acronym. So having all of that ready to go. And the next thing that you'll need for hypotension would be common practice and get you out of the tight bind if anything happens in the back of the ambulance. Very quickly, we'll tidy up the investigation. So you can see that this was text to me actually after our transport team got there, and it shows that the heart is enlarged, very white looking lung fields. And so this is actually grossly abnormal. And so getting that accurate information would be really important if this child had just received 40 mils per kilo and propofol was part of their induction plan, it would have been a different outcome. Some stills of the echo, which show dilated venous system, although they're on high pressures, dilated LV. And the ECG, we're not expected to be experts on ECG, but is sinus. There is some high takeoff, so some delta waves there. So they probably have an accessory pathway and it's set up for arrhythmias. They also have prolonged QT. So this patient likely had either SVT that caused a cardiac failure and then they decompensated, or a heart failure and vice versa that was causing an arrhythmia. But their metabolic screen was normal. Trainees often mention respiratory, and it's not part of the classic differential diagnosis for a collapsed neonate, but I've changed my mind over the years. So this picture is of a bit of plastic that was put into a neonate's airway by a sibling that didn't appreciate the crying. That syringe is just for scale. And so we do see late presentations of respiratory problems, pulmonary hemorrhages. All of these things would be treated by your ABC stabilization approach, but expect the unexpected. I've changed my mind over the years about the respiratory being part of the neonatal collapse. This again is just pulling back a bit and seeing what we're doing in terms of collecting data prospectively. So after 24 hours, we do follow-up calls, and we managed to engage with 10 other transport teams. So each letter down the bottom is a different transport team. And this is the extubation rate of all referrals that's over a 2-year period, so 1,600 patients. The percentage of extubation that's done locally for status epilepticus. So we don't know the accurate or the right treatments for these children. but there's huge variation in, or the most important factor on whether or not you get extubated lift is actually which area you present to. So, really taking an interest in collaborating can highlight different areas of practice. So this is 74% extubation, some areas transferring all of those to PICU. So I mention it as just to highlight that we can answer more questions if we work with other transport teams, and we probably do our own sort of randomized trials, but we need to be hungry for that data and go after it. So we'll be delving into these things and reporting our data, but we feed these back to the local hospitals. Again, of interest, we're also collecting patient observation data. So we can use these phones to transmit data, and we're working with some mathematicians to try and get some predictive modeling as well. So there's plenty of to come, and which will be interesting, but feel free to email me, message me if you have any questions about those extra things. Those could be talks in themselves. So it's a very brisk run through of some of the logistical and practical things that we look out for on a retrieval. I'd advocate you to love your checklists and guidelines. Really, to anticipate problems is the most important thing in the back of an ambulance. And then all of that data that I showed you, we're collecting now prospectively, and that we can feed that back to PICUs, to local hospitals, and hopefully make some changes in otherwise processes that haven't really changed a lot over the years. Thank you very much for your attention, and please, I don't know if we're doing questions now or at the end, but I welcome any questions.
Thank you, Dr. Knight, for this amazing lecture that you gave us. So my dear professor, Dr. Qarib, has got a question. So let me just, Dr. Qarib.
Thanks a lot, Dr. Philip. Thank you very much for your nice presentation.
Pleasure.
I have a question. What measures should the airway transport team do to prevent the possible harmful effects of low air pressure during airway transport? For example, if the child has pneumothorax and has chest tubes, is there any need for a special precaution or intervention to prevent the harmful effects of low airway pressure in high altitude in airway transport?
Fair enough. Thank you for your question. We would probably put chest drains in and drain air that was, say, in a pneumothorax. We'd have a much lower threshold for treating those things than if we were going by road. So yes, I guess the intervention that we do is that we're just more interventional in draining that air, so that we don't get complications in transfer. That's the main thing, and making sure that your equipment is compatible with air travel, which you would do far in advance as a team.
Yeah, thank you. Thank you very much, Dr. Philip.
Pleasure.
Phil, just continuing from what you have just been asked, if the question is if the child is on high pressure ventilation, for example, would you prophylactically put chest tubes in because you're going to go in the plane?
Right. I guess no is the short answer for me. You might end up causing more harm than good. And so it's very common for us to transfer on higher pressures than you would potentially see, especially as children are re-expanding. And so no is the short answer. We quite commonly transfer people on high pressures. But you're right to think about it. And if you are concerned about it, then you'd have your equipment ready to go. So if you're going to needle the chest, there's no point having that and the equipment in your bag in the hold. You'd have a cannula and equipment ready to go. So that would be part of the anticipated disease-specific things. I'd probably put it that, but I wouldn't put in drains unless they really need to be.
Perfect. Thank you.
Thank you, Dr. Knight, for this amazing conversation, for this informative lecture. As a pediatrician, I myself learned a lot. So thank you. Thank you for joining us.
Pleasure. Thank you very much.
Thank you. So for our next lecture, we're going to have dear Dr. Lidia Casanova. So dear Dr. Casanova got her Bachelor of Medicine and Bachelor of Surgery degree at Autónoma University in Madrid, Spain in 1997. She then obtained her Diplomate of National Board in Pediatrics in 2002. In 2007, Dr. Casanova completed her PhD at Complutense University in Madrid on end-of-life strategies in the PIC environment. And she gained qualifications in pediatric trauma initial care and pediatric and neonatal advanced life support in 2011. She's a pediatric intensivist at Royal Brompton Hospital, London right now. So thank you, Lydia, for joining us. This is such an honor. And we can't wait to listen to your lecture on non-invasive ventilation methods in critically ill patients.
Thank you, Mariam, for the invitation and the introduction. It's my pleasure to be here. So in the next 20-25 minutes, I'd like to give you a basic overview about non-invasive ventilation in children applied in the acute setting. But also I would like to share my experience regarding our NIV program that we started back in 2017, what we've learned and what can be also useful for you in your setting. So non-invasive ventilation is a respiratory technology that is applied worldwide across the globe. It can be used as primary respiratory support, post-extubation prophylactically, or to prevent reintubation. And also in a small percentage of patients, it can be used as a palliative care strategy to improve comfort. It is used in different settings: transport, emergency departments, the ICU, in some places in the ward. And it can benefit different respiratory illnesses. This is a nice study that was published in Pediatric Pulmonology in 2018. And they surveyed more than 100 PICUs in 23 countries. And you can see the high percentage in use of this technology. This is also a nice study. It's a little bit older, and it's a retrospective analysis of the use of non-invasive ventilation in 5 Italian PICUs. And you can see how within a 6-year period, the use of NIV, particularly in children with respiratory conditions, has exponentially increased. And also you can see in this other graph, the use depending on the respiratory pathology. And the dot line reflects the percentage of failure. And there is a big peak in those patients with moderate to severe ARDS. So in this group of patients, this technology needs to be applied cautiously. There are also another key element that they mentioned for percentage of success, which is to have a trained staff to be able to deliver and to monitor the therapy. So back in 2017, we started an NIV program. It's a multidisciplinary group with those doctors, nurses, and physiotherapists. And we start our program standardizing our practice, delivering guidelines, quick guides, and then try to establish that standardization of practice at the bedside with education and training, and audit what we do. So essentially, we meet every week, discuss the patients that we had on NIV, what problems, what troubleshooting, and then feedback to our practice and just repeat and cascade this teaching and education at the bedside in a consistent basis. And we use this systematic approach that I would like to share with you. I cannot take credit of it. This was first established by the group of Marty Bones. He's an intensivist that works in Barcelona and has done a great deal of work in the area of non-invasive ventilation in children. And it's an acronym that stands for indications, contraindications, equipment, modes, analysis of failure, and next step. And it can really be applied to any kind of technology that we use on the ICU. And I will explain in more detail in the talk. So non-invasive ventilation essentially is a respiratory technology that applies a constant pressure with a variable flow. And it can be delivered with one level of pressure that aims to recruit the lung, but also is beneficial in terms of strengthening the airway and also stabilizes the thoraco-abdominal dissociation that in patients with respiratory distress usually occurs. And when we apply a second level of pressure, a pressure gradient, we can also provide effective ventilation. With more sophisticated ventilators and technology coming up, we also can apply different modality of ventilation, but usually simplicity is better because with these more sophisticated modalities come more complexity in terms of monitoring and patient ventilator symptoms. So again, as with any technology that we use on NIV, we have three main elements. One is our patient, which in the case for NIV is an spontaneously breathing patient. Then we have our technology, our ventilator, and in between we have the interface. In this slide, what I want to show in the top graph, the three main components of the respiratory system. So the first dotted line represents the force of the chest wall, which tend to expand the whole system. And the second dotted line represents the resisted force of the lungs. The lung tends to collapse. And then there is a combine of these two forces. And when these two forces achieve an equilibrium, is what is called functional residual capacity, which is essentially the lung volume that is effective for gas exchange. Depending on the respiratory illness, this functional residual capacity can be suboptimal. And in this context is where NIV can improve that value and stabilize the patient. So there are two main groups of acute respiratory failure, although this division usually is not as clear. Normally these pathologies overlap. But I think it's useful in terms of how we apply non-invasive ventilation in our patients. So there is a big group of patients in which the main problem relies in the lung parenchyma. These patients usually present with hypoxemia. And for those patients, apply one level of pressure, CPAP, in order to optimize FRC and lung recruitment might be sufficient. And then there is another big group of patients in which the main problem relies on the respiratory pump, either the respiratory drive, the thoracic cage, or the respiratory muscles. And those patients usually present with hypercapnia. And in this group of patients, we usually will need to apply two levels of pressure, so bi-level support. This is an old but nice study that represents very well the physiological beneficial effects of non-invasive ventilation. This study was carried out in adult patients, and you can see how, as the investigators increase the level of pressure, both in hypercapnic and normocapnic patients, the pressure time product, which is a surrogate for work of breathing, nicely comes down. And the same you can see in the next graph as they apply different level also of pressure support. So essentially, the IPAP counteract the intrinsic PEEP, increase the lung recruitment, stabilize the airway, and improves the whole compliance of the respiratory system, whereas the IPAP offload the respiratory muscle and optimize the trans-pressure gradient across the system. In this slide, I want to show you that these are the different phases of the normal breathing, which start with a nervous impulse that goes down through the phrenic nerve to the diaphragm excitation. Then the diaphragm contracts, and that leads to chest wall and lung expansion, creating a pressure gradient in which the air flows in. This is what our ventilator, this flow trigger, this change in flow is what our ventilator unit will detect, and then the ventilator will provide an assisted breath. But really, when the patient wants to breathe, happens much earlier in the breathing phases at this level is when we have the neural trigger. So inevitably, when we apply non-invasive ventilation in our patients, will always be asynchronous in terms of triggering and a kind of a delay triggering, which it's important for us to recognize in order to try to optimize the relationship between patient and ventilation. So coming back to this systematic approach, this is exactly the methodology that we use at the bedside with our junior doctors and our bedside nurses in order to carry out this kind of way of thinking when apply this technology at the bedside. So I stands for indication. So it is important to answer this question, not only in which patient is indicated, but also very important in which patient is contraindicated. I'm sorry, because I'm just going slow. So for contraindications, we also teach them a systematic approach, ABCD approach. So it is essential that we have a patient with a patent airway or able to maintain a patent airway. Breathing, as mentioned before, those patients with ARDS, particularly at the initial stages in which we don't know the progression of that disease, or patients with moderate to severe ARDS, we have to be very cautious even to start. Patients with cardiovascular compromise, patients with a decreased level of consciousness, and the E stands for extra things that usually applies to a mask that is not appropriate or a ventilator that is unable to detect appropriately the patient effort. There are relative contraindications like non-draining pneumothorax or recent gastric surgery. But essentially, we advise to follow that systematic approach, ABCD. Then patients with any symptoms or physiological criteria of respiratory compromise will be good candidates for NIV. But again, requisites, we need a conscious and cooperative patient. We need a ventilator able to respond to patient effort. We need a well-fitting mask. We need to understand what is the underlying pathology and what can we expect. And super important, we need a skillful and expert team able to provide and monitor this therapy. Moving into equipment from the Iceman. Equipment covers both the mask, the interface, and the ventilator. In an acute setting, when the patient is compromised, we advise to use a full face mask rather than a nasal mask because the leaks are much more reduced when we use a full face mask. And this is some of the quick guides that we have developed in order to protect the skin. These are our full face masks that you may also use in your units. And as you can see, the elbow can color code. So blue elbow means that it's a non-vented mask, which means that there is no control leak. And these masks are used with the PACU ventilators. And then we have the orange elbow, which means that there is a control leak around the mask. It's a vented mask. These masks comes in 3 sizes. We've used, the smaller patient was 3 kilo patient, and up to 20 kilos you can use these masks. Alternatives to those are bucco nasal mask and nasal masks that you can alternate when the patient starts to improve. It is important that we don't dilate too much because otherwise we will have problems in terms of pressure sore, which will preclude us to continue with the therapy. Coming back to equipment, there are a lot of ventilators in the market, but essentially we can divide them in two big groups, depending on how they work. So we can apply NIV with our PICU ventilators if they have an NIV module incorporated. This is the one we use on our units, the V800. And these are pneumatic ventilators, which means that they receive the air supply and the oxygen supply from high pressure. So they need a pressure regulator to downsize the flow. They are used with double limb circuits, and the exhalation module is embedded on the ventilator. So with these ventilators, we need to use non-vented masks, and then can provide a variety of modalities similarly to what we have for invasive ventilation. And then we have turbine ventilators. These are specific NIV ventilators, and they are turbine, which means that they will regulate, according to the leads, the amount of flow that they deliver. They entrain the air from the environment, and these NIV ventilators, specific NIV ventilators, they are used in the acute setting. They have a blender, and these ventilators can provide up to 100% oxygen. But the limitation point is that only they can be used for more than 20 kilograms. As you can see in the diagram, they are used with a single limb circuit, which means that we need to use a control lead either in the mask or embedded in the circuit for CO2 exhalation. Alternative to those are portable ventilators. They are also turbine ventilators, but these portable ventilators, they again entrain the air and mix with the oxygen, and the limitation is that they cannot provide more than 50% oxygen. So we have to be careful when we use these ventilators in an acute setting. This more modern one, NIP4 and Trilogy Evo, if we provide them with 30 liters of oxygen, they can provide up to 70% FiO2. And the good thing is that they have very good monitoring capabilities, and they can be used in small infants as small as 2.5 kilograms. And obviously, I think we need a humidification of the system, and in some tubing, some accessorizers. So that's the equipment. Then moving on to modes, there are, as I said, a wide variety. The first thing that we need to decide is either we apply one level of pressure, CPAP, or two levels of pressure, bi-level. When we use ICU ventilator, the simpler modality, so the less parameters that the patients will need to comply with, the better for patient ventilator asynchrony. And my recommendation is always to start small, so 4 on 4 or 5 on 5, and then try to see the effectiveness of the therapy and at the bedside, particularly important in the first 30 to 60 minutes, try to optimize the therapy and monitor the patient response. In a small proportion of patients, the ones that are very weak or initially quite unwell, we can use a more controlled modality of ventilation. We can sedate the patient with some sedative in order to improve patient ventilator asynchrony, but take into account that the more parameters that the patient needs to comply with, the more difficult it's going to be for the patient in terms of synchronization. And it's very important to have in mind some target values and higher values. If we need to go up on our therapy, we need to go up on IPAC pressure more than 18, 20, we have to carefully think what we're doing, because these patients might need escalation of treatment. The M also stands for monitoring. So many of these patients may be admitted from emergency departments. So they may not have invasive arterial monitoring, but that's okay, because for this therapy, it's especially important how clinically the patient is responding. So in terms of work of breathing, oxygen requirement, and vital signs. The heart rate is a parameter that is very important. As the patient is synchronizing and improving, we will see that both parameters, heart rate and respiratory rate, start to settle down. And that means that the patient is benefiting from NIV. If we have an arterial line, we can always do our PiO to FiO2 ratio, but as a surrogate, we can always use saturation versus FiO2. And also in terms of monitoring, when we use ICU ventilators, we have to take into account that there are a lot of alarms that it won't be useful on NIV. And in fact, it will be nuisance alarms. So we have to learn which alarms is important to disable in order to make the ones that are important more meaningful. Alternatively, if you have these devices available in your unit, transcutaneous CO2 is a good way to monitor the therapy. In order to detect asynchrony, what we teach our bedside nurses and junior doctors is to be able to recognize what is normal, how a curve looks like, should look like. So we teach them to recognize what is normal. So we need to see this flow time curve, and we need to see that the baseline returns to zero, both in inspiration and exhalation. We also teach them the main inspiratory asynchrony or trigger asynchrony, which essentially is something that you have to do at the bedside. You have to look at the therapy, you have to look at the patient. This is an auto-triggering. So the ventilator is responding more than the patient is requesting. And essentially you have to see, this is how the curve look like when you have auto-triggering. So it's triggering more than the patient is requesting. And usually this is related to the leak around the mask. So you can try to traverse that, adjusting your mask if this is causing a significant problem. The opposite problem you can see, which is a mistriggering. And it normally occurs when the patient is requesting a breath, but the ventilator is unable to provide that breath that is requested by the patient. So this is a mistriggering. So this is very easy to recognize at the bedside, but looking at the graphs and by looking at the patient and the ventilator. In this case, usually the patient is too unwell or too sick or too weak, and it might be an indication for us either to minimize the death space or to provide a more controlled modality of ventilation in the initial basis. But always try to change to more spontaneous modality of ventilation by level support, CPAP, ASB, to minimize patient ventilator asynchrony. And also we teach them to recognize autoclive. So this baseline in exhalation, we need to go back to zero. And the last step is stands for need for escalation or de-escalation. As I cannot emphasize more, that is very important, particularly at the beginning, in the first 30 minutes, 60 minutes, to remain at the bedside and try to optimize the therapy and see what is the response. Because a delay on intubation, particularly in patients with ARDS, has been proven to worsen outcome and increase mortality. And this is just a bedhead sign that we start trialing in our patients. We have two, one in blue, which is for non-vented mask and PICU ventilators, and one orange bedhead sign for portable ventilators. And this is a teaching tool that is also a way for us to make sure that the patient, we are applying NIV safely and correctly. So we just go through our doctors and our nurses through this bedhead sign, making sure that all the right equipment is used, and teach them to recognize this basic patient ventilator asynchrony, and we have some red flags for escalation if the patient is not responding well or is developing complications or contraindications. So in summary, my take-home messages, again, through the Iceland algorithm: start early. Don't start if it's contraindicated. Make the best of your device, your equipment. Monitor. Non-invasive ventilation is fine. I think the clinical examination is very important. Pay attention to synchrony and stop early if it doesn't work. Thank you very much.
Thank you, Dr. Casanova, for this amazing lecture. I myself learned a lot. Thank you, especially the abbreviation, the Iceman. It was really new and interesting for me. So thanks for sharing that. I learned a lot myself. So if you may, I see a question in the chat section actually. So I might ask it right now before jumping to our next session. So if I'm pronouncing the name right, Mariam Al-Hamid, thanks for joining us, dear Mariam, and sharing your question. So she says that, Dr. Lidia, what is your opinion on using sedation for applying NIV in infants to increase their patient tolerance? Obviously, she's talking about the sedation drugs that do not suppress respiration, but what is your opinion on this matter?
Yeah, so usually if the patient is responding to the therapy, just by establishing a good non-invasive ventilation, it's settled down. But if you need to optimize the synchrony, particularly in the beginning, sedation is fine. We normally use the dexmedetomidine as a continuous infusion, particularly in those patients that are struggling more. But non-pharmacological measures, they're also quite good. But yes, so either a little bit of midazolam or dexmedetomidine is what we use in our units. And that's particularly when we use mandatory rate, because the synchrony is always tricky in those cases.
So thank you. Thanks for your response. So I don't see any other questions in the chat section. So I wanted to thank you again for joining us and for, oh, I see another one, sorry. So my dear professor, Dr. Gharib also is asked, is feeding by oral or NG tube appropriate with an IV?
So I guess it depends on the phase that the patient is. If they're in very acute phase, I would be cautious. It's important to use an NG tube for venting the stomach, because the leaks not only happens around the mask but also inside. As we are giving breaks or downsize to a nasal mask, it's okay to feed, but particularly in the initial phases, I would be very cautious.
Thank you so much.
You're welcome.
Thank you. So I would love to start our next talk. Again, thank you, Dr. Lidia. And I will start our next talk with our dear Professor Desai. So Dr. Desai completed his postgrad pediatric training in Mumbai, India. He gained further experience in pediatric intensive care and retrieve medicine in London at St. Mary's, Royal Brompton, and Great Ormond Hospitals, and the Children's Acute Transport Service. He supplemented his cardiac intensive care training with a year of fellowship in pediatric cardiology at Royal Brompton Hospital prior to his appointment as a consultant in 2010. Dr. Ajay Desai is a consultant in pediatric intensive care medicine at Royal Brompton Hospital right now. He is the lead for the pediatric extracorporeal membrane oxygenation, or ECMO program, with a special interest in extracorporeal cardiopulmonary resuscitation, or ECPR, and lead for pediatric integrated care pathways. Dr. Desai is deputy college tutor and lead for the Junior Doctors Education and Training Program at the Trust. He also is a member of the Simulated Interprofessional Team Training Program faculty and has been a member of Education Committee of the International Pediatric Simulation Society since 2010. So thank you, Dr. Desai, for joining us again this year. We heard an amazing lecture from you last year as well. So this is such an honor to have you again with us this year, and we are more than happy to listen to you.
Thank you, Mariam, for your kind introduction. So in the next 20 to 25 minutes, what I was going to describe is take you through blue baby scenarios without wasting more time. So what I would like to cover is how do we approach a cyanotic newborn baby? What could be the differentials, and how do we use prostaglandin E2, or commonly known as prostin? As we go along, we will do some case studies with some key learning points. I will also cover very briefly persistent pulmonary hypertension of the newborn, and I will mention very briefly about some of the key ECMO considerations, and I will summarize. So as Phil was describing earlier, even though I'm talking about a blue baby, we should always have a structured approach. As we all know, in intensive care, structured approach is so that you don't miss any obvious things. So if you're faced with a blue baby, always start with the airway and then move on to the next steps. So it could be breathing issues like congenital pneumonia or congenital lung anomalies. And finally, we come back to the circulation, which will be my focus of this talk. So within circulation, you can have a cyanotic congenital heart disease with decreased lung perfusion. For example, pulmonary atresia or tetralogy of Fallot, tricuspid atresia, Epstein's. You can have congenital heart disease with mixing of blood, the classic example being transposition of the great arteries. We can have persistent pulmonary hypertension of newborn. Either it could be primary or it could be in association with sepsis or meconium aspiration. And finally, you can have congenital heart disease with decreased systemic flow. For example, critical aortic stenosis or coarctation of aorta. Although that particular group doesn't present initially as a blue baby, eventually when there is cardiogenic shock, they will be hypoxic. So the heart conditions, there are a variety of modes of presentation. For example, how old is a patient? A day one newborn who is very blue, you can have certain differential diagnosis. And what are the symptoms? For example, is the child very unwell or the child looks relatively stable? And then you can have signs. For example, is there an arrhythmia or is there a cardiovascular collapse, which we will take you through some of the clinical scenarios. It always starts with a good assessment when you are faced with a small baby who is looking blue. Always start with a pulse. Normally what we would recommend is simultaneous palpation of brachial and femoral is useful. Because if you only palpate femoral pulses, then they may be still present even in presence of coarctation of aorta, but that the tone of or the force of the femoral pulse will be low. Unless you compare with brachial, you may miss that. Forelimb blood pressure, we all know about that. We will also take you through pre and post ductal saturations, which is often used in babies with congenital heart disease. And it is also important to look at the ECG. For example, what is the rhythm? Is it a abnormal tachycardia or bradycardia? Axis is important in some of the blue babies. For example, a left upper axis deviation might point to, for example, Epstein's or tricuspid atresia. It is also important to note, are you finding any signs of ischemia on the ECG? For example, in Al-Kappa, you might find ischemic changes. Then go through the chest x-rays. We look at how the lungs are there increased pulmonary vascular markings, or is it very oligemic? What's the heart size like? Is it big? Is it normal? And then what about hyperoxia test? When we were trained, we heard about a lot on hyperoxia test. Basically, you supplement the child with 100% oxygen. and then you do an arterial blood gas. If the PaO2 is more than 34 kPa, then you can conveniently exclude cyanotic congenital heart disease. I know there may be different units practiced. For example, just for the audiences, kPa is what we use in UK, but if you want to convert that into millimeters of mercury, you need to multiply that by roughly 7.4. And so when you supplement the patient with 100% oxygen, and if the PaO2 does not increase significantly, then it is not confirmatory. It could still be cardiac, or it could be a lung problem. And hyperoxia test has its own limitations and utility. Moving on to this differential cyanosis. So I mentioned about pre and post ductal saturations. For example, I have drawn a simple picture showing pulmonary artery, the duct, and the aorta. What you can see here is the blue blood from the pulmonary artery goes via the duct into the descending aorta. So this is a pulmonary to systemic shunting, which you can often see with pulmonary persistent pulmonary hypertension of the newborn, or you can also see that with coarctation of aorta. So in these conditions, your pre-ductal saturations are higher than post-ductal saturations. Now, in case of a simple TGA with low pulmonary vascular resistance, here I have drawn, because it's TGA, the aorta is blue because it's carrying venous blood arising from the right ventricle, and the pulmonary artery arising from the left ventricle carries red blood. And because the pulmonary vascular resistance is low, you always have both systolic as well as diastolic flow across the duct from the aorta to the pulmonary artery, that is systemic to pulmonary shunt. So here you get pre and post ductal saturations that are nearly similar. When do we call a significant difference? If the difference is more than 5 to 10%, then it becomes significant. Now, in case of TGA with either pulmonary hypertension or coarctation of aorta, as you can see in the picture I have drawn here, you get pulmonary to systemic shunt. So here in this case, the pre-ductal saturations are lower than post-ductal saturations. In other words, this is what we used to learn as reverse differential cyanosis. And you might ask why we are so focused on pre or post-ductal saturation. One, it gives you the underlying pathophysiology, what's happening at the level of pulmonary vascular resistance. But also remember, the pre-ductal saturations are important because that is the blood that is supplying oxygen to the brain. So if pre-ductal saturations are low, I would be more worried because the brain is becoming hypoxic. So what about chest X-ray? On the left-hand side, you can see increased pulmonary vascular markings. The heart size is not that enlarged. And considering that there are no other abnormalities, here your differential diagnosis could be, it could be RDS, it could be transient tachypnea, could be sepsis. But the key element with respect to the heart disease is that the heart size is quite normal, okay? So if a patient is a newborn baby who is collapsed and is needing escalating mechanical ventilation support as well as inotropic support, becoming hypoxic, and you have that picture on your left-hand side, because of the normal heart size, the suspicion for obstructed TAPVC becomes much higher on the list. On the right-hand side, you got a large heart, so obviously cardiomegaly, and the differential diagnosis for cardiomegaly in the newborn period, it could be hypoplastic left heart, it could be Epstein's anomaly, it could be pericardial effusion, or it could be neonatal myocarditis. So if you look at here, the case one, a 6-hour-old, these are all real cases I'm highlighting for the purpose of education. So 6-hour-old male neonate, full-term normal delivery, no risk factors for sepsis, mild tachypnea, otherwise well. Saturations are 86% in air. And this is the chest X-ray, which is obviously a massive cardiomegaly. So here you can look at the ECG. I will try to highlight some of the key aspects of the ECG. You can see some delta waves there. So a large heart, delta wave on the ECG. So suspicion for Epstein's anomaly is very much high on the list. Okay, obviously this needs to be confirmed with the echo. On the left-hand side, you see two hearts. The extreme left, that's the Epstein's heart, and I have put in the normal heart size of a neonate for comparison. So you can appreciate when we say massive cardiomegaly, what it looks like. On the right-hand side, you see that the echo finding of the RV is actually very, very tiny. The RA and ARV is atrialized right ventricle, massive right heart, very typical of Epstein's anomaly. Here we have a 16-year-old male infant, term baby, normal vaginal delivery, no risk factors on postnatal ward. Child is grunting now, cyanosed, SATs of 60% in air. So the baby was taken to neonatal intensive care unit, intubated, ventilated, IV access, fluid, and the SATs improved to 80% on 100% oxygen. Chest X-ray, unremarkable. I have shown you the ventilator settings, and the arterial blood gas shows pH of 7.2. I'm not going into details, you can see it for yourself. So this was referred to our unit, and because it's our cardiac center, either we had the option of accepting this baby because we had one bed, this is in the middle of the night. But if this was, let's say, more of PPHN, then the child could be managed elsewhere. So as you know, the PICU beds are premium, and we need to be sure that we are bringing in cardiac babies. So here, what could be the differential diagnosis, or how we made our clinical judgment? You can see that the CO2 is 3.1. When we say CO2 is 3.1, it means that the gas exchange is happening very well in the lungs. That in turn means it is very unlikely to be PPHN. In persistent pulmonary hypertension of newborn, there is the gas exchange in the lung is very limited, so you get very high CO2. So on the basis of CO2, we thought this could be more of TGA problem rather than PPHN, and we accepted this patient. So what initial advice we give? Always start prostin, that is prostaglandin E2. Never ever think of prostacyclin, which I'll come to that later. Then as soon as you come across this baby in a district general hospital or in accident and emergency, first thing is you start prostin, and then you start the referral process. This child needs to go to a cardiac center as soon as possible. Obviously, you monitor pre and post-ductal saturations, urine output, and lactate. And when the child arrives in a cardiac center, or if you have the facility when you see the patient, echo is important to check the adequacy of interatrial communication, patency, and direction of flow across the duct. Remember, if you have a patient with TGA, an ordinary IV cannula, even that is very important, because if you inject any tiny air bubbles into the peripheral veins, they can straight away cause stroke. So be very careful. This is not a common circulation. Treatment for any duct-dependent heart disease, start prostin. As I said, it's either dinoproston or alprostadil. It is very important to convey to the team do not use the words like prostacyclin or epoprostenol. They are pulmonary vasodilators, and their role in intensive care is very different in the management of pulmonary hypertension. So avoid confusion. That's a key message here. There are some practical considerations for Prostin. The first one is access. We always say have 2 peripheral IV lines before you start Prostin, because Prostin has got a very short half-life. It's around 2 to 3 minutes. So in case you are transferring the baby and you lose an IV access, then it may cause a lot of problem. Then starting dose, if it's a stable baby but blue, we normally advise 5 nanograms per kilo per minute, and then continue that. But if the baby is very sick, that is collapsed baby, child is already intubated, lactate is high, systemic perfusion is very minimal, then you can start at 10 to 20 nanograms per kilo per minute, and you can increase it quite rapidly at 10 to 15 minute interval. You can just keep doubling it. We have used doses of up to 100 nanograms per kilo per minute in order to open up the duct and transfer the baby ASAP. Infusion rate and implications. It is very important to understand that any peripheral line will have some dead space. So if you're starting Prostin at a very low dose, remember it will take at least 20 to 25 minutes to enter the circulation. So you might want to wait for that time and see the response, or you might want to start at slightly higher rate and then come down. Okay, but if you are in an emergency, start at a higher dose. And what do we monitor? Heart rate, blood glucose, temperature. Some of the side effects of Prostin are, tachycardia, hypoglycemia, fever. But please remember, side effects of Prostin can be managed, but it's important to get the effects of Prostin right. Okay, if you are unable to open the duct with Prostin, do not be scared to increase the dose rapidly. And another key question people often ask is whether we can give oxygen on Prostin, because oxygen tends to close the duct. So my message is, if you are using Prostin, you can use as much oxygen as required. So it will not have any negative effect on the ductal issue. In case of emergency, as I said, you suddenly lose an IV cannula and the child is dependent on high dose Prostin, you can give the same solution through the oral route, that is nasogastric tube, let's say 50 microgram per kilo every 1 to 4 hourly. And lack of response, check whether the dose is right, check whether you are giving enough, check whether there is any delivery issue, or sometimes it may not be a heart disease at all. For example, it may be something else. So keep an option open. Prenatal diagnosis has dramatically influenced postnatal management of blue baby. In the past, at least in the UK, it was only 4-chamber view what the obstetricians used to perform. That way, you could have still missed transposition of the great arteries. But now the protocol does include viewing the outflow tract. So as I said, prenatal diagnosis is really, really important. We rarely come across these days a blue baby who has not been diagnosed prenatally. So this is the third case. It's a just born female neonate, antenatal diagnosis of tetralogy of Fallot. Baby is centrally cyanosed, otherwise warm, well perfused. Pulses are all well felt. 3/6 ejection systolic murmur at the right lower sternal edge. The saturations are 82% in air. So the common question or dilemma at this stage is what to do. And the answer is do nothing. You simply accept this is where we expect the saturations to be. As long as the baby is warm, well perfused and feeding, carry on feeding and needs follow-up with the cardiology team. So that brings to one of the key questions of what are the diseases and what sort of saturations we should be expecting. Because if you don't know what saturations to expect, then we start reacting to every number. So in a standard tetralogy of fellow, saturations between 75 to 85 is acceptable. And in a pink tetralogy of fellow, for example, a very large VSD or with a minimal right ventricular outflow tract obstruction, saturations can be in the high 90s. In case of TGA with intact ventricular septum, saturations in the 70s to 80s is acceptable. TGA with VSD will have saturations maybe even up to 95 or 100. Epstein's 70 to 90 is fine, and hypoplastic left heart saturations in the 70s is acceptable. But please do understand that every disease has an extension of morphology, and also the presence or absence of pulmonary vascular resistance and the degree of intracardiac mixing will have some influence on the saturations. And it does impact on how do we use prostin. Now, briefly about perinatal physiology. We all know that fetal circulation is shunt dependent and it's a parallel circulation. Rapid and significant changes happen at birth. The drop in PVR soon after the baby is born is mainly due to increase in PaO2. There are 3 intercirculatory shunts that must cease to exist after the baby is born. Obviously, the first one is the ductus arteriosus, then we have foramen ovale, and we have ductus venosus. Now, what about PPHN? In a nutshell, PPHN is failure of normal postnatal fall in pulmonary vascular resistance. And this will lead to marked hypoxemia because of right to left shunting at the atrial level and also at the ductus arteriosus. PPHN could be either primary or secondary. The X-ray on your left-hand side is called, in a very simple way, black lung PPHN. Looks very unlikely to be secondary to sepsis or any other obvious cause. Whereas on the right-hand side, it could be pneumonia, it could be sepsis, or it could be RDS or meconium aspiration. Echo should be performed to exclude any cyanotic congenital heart disease and also to assess the ductal and other shunting. So this is the classic picture, echo picture of pulmonary hypertension. The horizontal line below that, below the baseline, what you see is flow in systole, and above the baseline, what you see is flow in diastole. So in other words, it is a bidirectional shunt across the duct. Very broadly, the treatment strategy will include maintaining adequate systemic blood pressure, the judicious use of inotropes, decrease pulmonary vascular resistance. Oxygen is the best pulmonary vascular dilation, and make sure you ensure oxygen delivery to the tissues. Okay, and while we do this all treatment strategies, we must ensure we minimize the side effects of high levels of FiO2. For example, using 80 to 100% oxygen for more than 6 to 8 hours has caused toxic effects. Circulation, optimize preload. We need to improve mixed venous saturations. That is a reflection of cardiac output. Inotropes and vasoconstrictors, make sure the goal here is to raise the systemic pressure more than the pulmonary pressure so that the shunting will reverse. Instead of pulmonary to systemic, it could become systemic to pulmonary so that the oxygenation improves. You can use different agents. We have stopped using dopamine. So we either start with adrenaline, plus minus either NORAD or vasopressin. Vasopressin has some advantages in pulmonary hypertension because it selectively increases systemic vascular resistance without affecting pulmonary vascular resistance. Milrinone to be used very cautiously if you are struggling with low blood pressure. So the pulmonary vasodilators, either you can have nitric oxide or sildenafil, which use cyclic GMP pathway. The other agents are more reserved for protracted pulmonary hypertension group. Prostacyclin, we do use it once in a while as an adjunct. Nitric oxide, if the oxygenation index is more than 15, we start nitric. Just to explain what we mean by oxygenation index in very simple terms, it is how much pressure and oxygen you are giving the patient divided by how much oxygenation is actually happening in the body. Okay, now higher the oxygenation index, it means you are delivering more oxygen and more mean airway pressure. So the dose of nitric oxide can vary between 5 to 20 parts per million. Obviously monitor methemoglobin, and weaning you can take place once you get some stability. Magnesium sulfate can be an adjunct. It's important to remember normothermia is good to manage pulmonary hypertension. Don't keep the child very cold. Antibiotics are always helpful. You never know if it's a sepsis. Oxygenation index of more than 40, up to 80% mortality has been described. Oxygenation index more than 25 over many hours, the mortality increases at all ages. So early referral is important. There are some limitations of OI in neonates. It requires an arterial blood gas. It's only intermittently measured. Just a brief word about ECMO. If you're struggling with PPHN, this is Prof. Bartlett. He put the small baby you see, her name was Esperanza. She was a Mexican immigrant, moved to United States in 1972, and she was the first ever baby to go on to ECMO, and she's still alive and well. And please perform a head ultrasound scan if you're considering ECMO. So the key learning point here would be understand translational circulation. If you are having a baby with PPHN, protect the lungs and brain. A good basic intensive care management should help managing PPHN. And early ECMO referral, because the prognosis is very good. 90%, at least 90% of children come out well if they are offered ECMO when your conventional treatment fails. So do not delay ECMO referral. So last couple of cases here, term baby, day 1, cyanosis, SATs of 70%, maternal history of non-steroidal anti-inflammatory drugs during pregnancy. So this is the ECG, which shows very hypertrophy of right ventricle. You can see large negative deflection in AVL, and you can see tall R waves in the right precordial leads. On the right-hand side, you see the echo picture. The RV is severely hypertrophied. So this is a classic picture of premature fetal closure of the arterial duct. So very briefly, what happens is the fetal RV is responsible for 2/3 of cardiac output during fetal life. And most of that blood from RV through the pulmonary artery and the duct goes to the systemic circulation. Now, the picture shows where the ductus arteriosus is. The vessel you see is a pulmonary artery with the branches, and then the ductus arteriosus moves forward. Now imagine that ductus arteriosus is closed prematurely. So then you have a variety of consequences. One, you will have a very thick walled pulmonary arteries. At the top you see, that is persistent pulmonary hypertension. That there is regurgitation of the pulmonary valve. On the extreme right-hand side, You will see some dilatation of pulmonary arteries. So there is a combination of pulmonary regurgitation and stenosis. And at the bottom, you see massively dilated pulmonary arteries and branch pulmonary arteries. Okay, so the premature ductal closure can present in a variety of formats, all characterized by pulmonary hypertension. Majority, they require observation and oxygen. Some require ventilation and pulmonary vasodilators. Only a minority of patients require ECMO. Last but not the least, this is just for the audience to think about. So we have a 3-day-old male infant, feeding well, warm, well perfused, appears quite blue. Examination is unremarkable. Saturations, 86% in air, pre and post-ductal are same. Not much response to oxygen. Chest X-ray is normal. And we try to draw the blood sample for blood gas, and this is the color of the blood. Normally, I would have asked when I use this example for teaching. So this is an unusually brown colored blood. Some of you may have already guessed it. So this is congenital methemoglobinemia. The treatment would be slightly different here, either vitamin C or methylene blue. So just to summarize my talk, blue baby is not always cardiac, but prostin should always be considered. Do not shy away from administering oxygen if you are using prostin. It is also important to understand what should be your target saturations. And never ever forget sepsis. Start antibiotics until you get culture results. You must always have a systematic approach to blue baby. Antenatal diagnosis does improve outcomes. Clinical examination and investigation has to be systematic. And if you are struggling, early referral is the key. The earlier you refer, the outcomes are always better. And PPHN, as I described earlier, understand the key circulatory changes at birth, and key management principles include minimize O2 toxicity, minimize ventilation-induced lung injury, and early ECMO referral. Thank you very much. Any questions?
Thank you, Dr. Desai, for thank you, Dr. Desai. Oh my God, my voice is echoing, sorry. Okay, sorry. So thank you, Dr. Desai, for this amazing and educational lecture. So I myself learned a lot. Actually, I'm enjoying this session. Thank you, all of our lecturers so far. And it was really interesting. Actually, the parts that you were discussing, the cases, they were really, it engaged us, and I myself as a pediatrician put myself in the place of a pediatrician who is seeing this patient for the first time, and what would I do especially in a resource limited hospital. So it was really educational, and I would love to thank you for this. And especially the last case that you said about the methemoglobinemia in the neonate. So why would a neonate have methemoglobinemia? Oh my God, that's a hard word.
Methemoglobinemia. It can it can be congenital, or it can come later.
So when a neonate on the 3rd day of his life has methemoglobinemia, so it's probably a congenital one?
Correct. Correct. And the reason why I highlighted that, these are all real cases, and that's why I'm putting that. And sometimes the same baby, you start prostin and things don't improve. And this is a bedside diagnosis. When you're drawing the blood, it is neither red nor blue venous blood. It is classic chocolate brown. Okay, so immediately you know what's the problem.
Yeah, thank you. So, dear Dr. Qarib, if you wanted to.
Thank you very much, Dr. Desai, for your very nice presentation. I am very grateful. I have 2 questions. Are there any congenital heart diseases that got worse by prescribing prostaglandin? We know that sometimes Epstein's anomaly got worse by prostaglandin and circular shunt, but is there any other CHT, for example, TAPVC? Thank you.
Yeah. Okay. So I understand your question. I mean, I would like to also extend the specific example you raised, TAPVC. Sometimes people also wonder, should we give oxygen? Should we give nitric if the baby is very unwell? Because if you give oxygen or if you give nitric, there is more pulmonary blood flow, making the situation worse. But take it from me, we see this very often. And the key principle here is just to stabilize, transfer, make a definitive diagnosis, and treat. So when we are faced with a baby who is struggling, at that stage, I have not seen any child who is made worse by starting Prostin. The most common problem we see is either we are not giving enough Prostin or we are delaying starting Prostin. What you mentioned about circular shunt or on the in Epstein's or let's say nitric in TAPVC, they're all theoretical risks. But before those things happen, the child will stabilize temporarily.
Yes, thank you.
Once you stabilize, then of course, you got some control. You do a more definitive diagnosis. You have a multidisciplinary meeting, and you go whichever way is most feasible.
Thank you. And what are the disadvantages of dopamine? Because in here we use a lot of dopamine. Our anesthesiologists, they do not like it, but our cardiac surgeons, they insist on prescribing dopamine. Okay. So we know that in Western, in developed countries, they do not use dopamine a lot, but we use it a lot. What are the disadvantages? And we don't have vasopressin here.
Okay. So, I mean, easy things first. Yeah, if you do not have vasopressin, I mean, don't worry too much about it. But if and when, if you have an option, then you can consider. So that's about vasopressin. Now, regarding dopamine versus adrenaline, that's a common debate which used to be there for quite some time. Dopamine, although we look at, in our textbooks, traditionally, low dose dopamine, then renal dose, then beta dose, then alpha dose. Actually, we don't know when we start dopamine, whether you are using which, at what dose and what actions predominate. So in other words, it is not really predictable. Yeah, that's number one. And number two, dopamine was thought to be the only pressor which you can give, through a peripheral line. That was the so-called advantage of dopamine over other drugs. But on the other hand, when we use, let's say, adrenaline or noradrenaline, you can use them through a peripheral IV line. There are publications on that. And let's say if you are using noradrenaline, you know what exactly you're doing. That is vasoconstrictor. And if you're using adrenaline, you know exactly how you can titrate. Okay, so, and adrenaline, one is a pump function and the other one is at lower dose, it is still a beta effect. So very broadly, the argument that dopamine can be given peripherally and adrenaline not, that is not true. You can use that. Secondly, dopamine has got range of side effects. The side effects are more compared to the effects of dopamine. I'm not saying, I'm sure many centers are using dopamine and they are okay with it. That's absolutely fine. I'm not asking you to change your practice, but predictability is much better with use of combination of adrenaline plus minus NORAD or milrinol.
Thank you very much. Thanks a lot.
Thank you.
Thank you, Dr. Desai. So before going to the next lecture, so I see a few questions in the chat section, so I would love to ask them now. So the first question is that Mariam asked again, so more invasive methods of oxygen delivery cannot be started before prosting when we are suspicious of a duct-dependent problem, especially when we do not have echocardiography. So I think you talked about it a little bit right now, the balance between the avoiding hypoxia and also
Yeah.
not harming
I
the
mean,
baby. Yeah.
yeah, I totally understand. We may not have echo at the bed space. All I'm saying is, a sick child, think of heart, think of sepsis. So you
Mhm,
start antibiotics, and if you're thinking of heart, start Prostin and give
mhm,
oxygen if required.
mhm,
I mean, you don't have to wait for one to complete the other. You know, uh, start Prostin infusion, give oxygen if required, start antibiotics.
mhm. And having in mind the targeted saturations that you were talking about during your lectures. Yeah.
Yeah, but I mean, those targeted saturations, provided you know the underlying problem, but sometimes we
Mhm,
don't know.
mhm,
All I'm trying to say is saturations in the 70s to 80s, by and large, for a heart
mhm,
disease is reasonable.
mhm, mhm. Thank you. So I see another question in the chat section by Rosie. So Rosie, thank you for joining us. What is the most dependable factor to differentiate cyanosis of a baby due to difficult labor because of face presentation and dropped saturation on monitoring from true anatomic or functional causes in the first few hours of life of 1-day-old infant in the acute setting with a tired newborn?
I mean, it is likely to be at least one or two factors I can see in that presentation. One, it is a traumatic delivery, so
Mm,
the pulmonary vascular resistance will not have come down. And also whether there is any retention of fluid or transient tachypnea of newborn and that sort of thing.
mhm,
As I say, I mean, at presentation, sometimes it is hard to distinguish what is what. That is why it is important to have safety first. In other words, if you are in doubt, start Prostin. It doesn't do harm.
mhm,
You can give oxygen and you give antibiotics. That's a broad first line I want to highlight.
mhm,
And with time, then you do a chest X-ray. You can do an echo. You can think of an ECG and other examinations as and when the baby becomes stable.
mhm.
Okay. The first few
Just
hours,
mhm,
anatomic or functional, it is very difficult because the duct is open at that stage. The foramen ovale is still open. So you really don't know unless you have an echo.
mhm. So just one small question for myself. So about what you're talking right now. So when we want to start both antibiotic and also the prostin, so what dosage of prostin so you suggest we start our patient where we don't know if
Yeah,
it's cardiac or not?
yeah. If the baby is sick, I would
Mm-hmm,
say at least 10
mm-hmm,
nanogram per kilo per minute. But if you don't see the response within 10 to 15 minutes, when I say response, the
mm-hmm,
pulse, peripheral pulses, femorals should improve, the oxygenation should improve.
mm-hmm,
So 10 to 15 minutes, you must see an improvement,
mm-hmm,
okay, because of the half-life of prostin. If you don't see an improvement, escalate it,
mm-hmm,
okay? So, and simultaneously start referring and get additional investigations.
mm-hmm. Okay. Thank you, Dr. Desai. Thank you. We're a bit past our time, but it was such an amazing lecture and a lot of questions. Thank you for joining us. It was such an honor. Thank
Thank you
you.
for your kind invitation. Thank you.
Thank you. So for our next lecture, we will have dear Professor Akash Deep. So Professor Deep is Director of Pediatric Intensive Care Unit and Staff Governor at King's College Hospital in London, UK. He's a professor in pediatric critical care also in King's College, London. And also he is clinical lead of pediatric intensive care for South Thames Pediatric Network. Professor Deep is Chair of Scientific Affairs at European Society of Pediatric and Neonatal Intensive Care and Chairman of Science and Education Committee at Pediatric Critical Care Society. He's founding chair of Critical Care Nephrology Section at European Society of Pediatric and Neonatal Intensive Care. So thank you, Dr. Deep, for joining us. Sorry for a bit delayed, and we can't wait to listen to your lecture. Last year, your talk was such a hit. We are ready to be blown away.
Thank you. Thank you very much for the kind invitation. And as expected, I always struggle to share my screen. Sorry, 1 second, please.
Totally fine.
Can you see it now?
Yes. Not on slideshow mode, but we can see your slides.
You can. Okay, give me 1 second, please. Can you see it now?
No. Yes.
Sorry, I have to go right back. Sorry.
Totally fine.
Great. Thank you very much, Mariam, for this kind invitation for me to organize this for this session. And I think it's always a challenge to come after such eloquent speakers. Phil, Lidia, and Ajay have given you a very nice insight of how to manage the transport, how to manage a cyanotic baby or a blue baby, and then we heard about non-invasive ventilation. So my talk is going to be very much based on intensive care rather than critical care. And I'll be talking on acute liver failure. Why is it an enigma for the treating pediatric intensivist? So what I'll do in the next, say, 25 minutes is to take you through the definition of acute liver failure, why we struggle with that. We'll take you through a case scenario, what happened at King's. It's a real case. What are the controversies in the day-to-day ICU management of pediatric acute liver failure? What are the game changers in the management today, and what is new? And can we say after a few years that acute liver failure can be a curable disease? Is it a fact or is it a fiction? What I will not cover in my talk is liver transplantation in the setting of acute liver failure, because that in itself is a whole topic. So what is the definition? Why do we need the definition? I think as with any other disease, we need the definition for treatment decision. When should we start treatment? And it's very important if you want to do research and want to compare your results, if the definitions are different, you will not be able to do any comparative studies. So this is what happened in 1970s when John O'Grady at King's defined fulminant hepatic failure, that's what it used to be called, in adults as a massive liver necrosis with encephalopathy developing within 8 weeks from the first signs of illness in a patient without underlying chronic liver disease. And I want you guys to concentrate on this red maroon bits: encephalopathy, the timing, and without underlying chronic liver disease. The problem with children is that encephalopathy in them is often a late terminal event. It's difficult to diagnose, particularly in infants. For example, if an infant is irritable because the child is hungry, or the mother or the parent has gone down, it's very different to if an adult was irritable. We would straight away categorize the adult into stage 1 encephalopathy, whereas in children, it's very, very difficult. We talked about underlying liver disease. In adults, I understand that, but in pediatrics, it's frequent. And these are the diseases which either are present, for example, neonatal hemochromatosis starts from the gestational period. So there is a disease present right from the gestational period. The newborn is born and gets acute liver failure. It is still classified as acute, though the disease started long back. Wilson's disease is a classic example. The child is normal, 9, 10 years. Something happens, Wilsonian crisis, and that comes to light at that point. So which means that this disease is already present, but gets precipitated for the first time. So underlying liver disease can be present. Based on this, professor at King's, Georgina Meli-Vergani, then introduced the concept of multisystem disorder, in which severe acute impairment of liver function with or without encephalopathy occurs in association with hepatocellular necrosis in patients with no recognized. So she's using the word, it might be present, but it might not have been recognized at that point in time. So the pediatric acute liver failure group in the US then summarized everything and said, no known evidence of chronic liver disease. There is biochemical evidence of acute liver failure, but if you concentrate here, INR more than 1.5 with encephalopathy or more than 2 with or without encephalopathy. So very important that encephalopathy is not essential for the diagnosis of pediatric acute liver failure. Now, no talk on acute liver failure can start without the story of Prometheus. So Prometheus was a Greek god. He stole fire from the mortals, and as a punishment, you can see here, he is chained and his liver is left exposed to this vulture. So the vulture would come, eat on the liver and go away, and every few days, this liver would regenerate. So that gave us a concept that liver can regenerate, one, and B, you don't require a whole liver to be transplanted, only a small piece or a split liver transplantation can also suffice. Now, if you look at this liver, this looks like an architecturally normal liver. But this child has got an inborn error of metabolism with this liver associated. If you look at this liver, it's a completely destroyed architecture of a cirrhotic liver. But in between, you see here the green bits, these are the regenerating nodules, and this red bit is a collapsed architecture. And it's this balance or a fight between the regenerating nodules and the collapsed architecture which would decide whether this patient will end up getting a transplantation or this liver is going to regenerate with just the medical therapy. And you can see here, it's regeneration here. And if you don't the liver doesn't regenerate, ends up getting a transplantation. And this diagram nicely shows you the natural history of acute liver failure. Patient is normal here, liver function are falling down very quickly. If the patient does not get a liver transplantation, on the waiting list, the child dies. So this is death on the waiting list. On the other hand, this patient can get a liver transplant and survive 80-85% of the times. But sometimes this patient dies post-transplantation about 10-15% of the times. And what we are interested in is this line where the medical therapy alone makes the child recover from acute liver failure. So 4 outcomes we're talking about. We're talking about survival with transplant. We're talking about survival with just the medical therapy. We're talking about liver transplantation success, and we're talking about death post-liver transplantation. So this is an interesting slide where you see this is a pre-transplantation era. About 72% of patients would die. So only 28% patients would survive. And then came the advent of liver transplantation. You see here that liver transplantation is in green. More and more patients started to get liver transplantation. But if you look at the recent data from the US, 73.4% of the children were able to survive without a liver transplantation. And very importantly, 10% of all patients who were listed for emergency liver transplantation were delisted due to spontaneous recovery. So very important to realize that liver transplantation is not the only cure. The modern science is making us think that the children can survive without liver transplantation. So let me take you through this case which presented to us in 2017, where an 11-year-old male had history of vomiting and diarrhea for 3 days. It self-resolved. 2 weeks later, the child presents to Dublin with distension of abdomen. He was feeling tired, pruritic. He was jaundiced, and he was transferred to King's for grade 3 encephalopathy. At that point in time, you had a sky-high bilirubin, your alkaline phosphatase was low, and look at the INR, 9.3 here, low platelets, low fibrinogen. Wilson's was confirmed, and the patient was super urgently listed for liver transplantation. This is the course over the next 48 hours. You can see here that the patient is slipping into multi-organ failure. There is progressive respiratory failure. The child is on high frequency nitric, PF ratio is less than 100. Child is on 3 inotropes. Ammonia is high. Patient is in grade 3 encephalopathy, and we start continuous renal replacement therapy or dialysis right on day 1. You see here, we were neuromonitoring this child, and the reverse jugular venous saturations are going up, which means that the brain is not extracting enough oxygen. And if you look at a lactate is persistently more than 7-8. This is despite being on dialysis. So we are not able to clear the lactate, and the brain is suffering. So we insert an ICP bolt at this point in time. The opening pressure is 48. Everything is thrown at the child, including hypothermia, thiopentone infusion. We optimize the dose of our renal replacement therapy to 100 ml per kilo. Fortunately, the ammonia comes down and there is no change in the pupils. So this is how the X-ray looked like. And at this point in time, the child remained very, very, very unstable. You have a child on 100% oxygen. Child is acidotic with a lactate of 11 and still on 3 inotropes and vasopressors. The question is this child transplantable at this stage? What should we be offering? The parents were worked up and their liver was not good enough. So we were waiting for a cadaveric liver to become available. We had an MDT discussion, and the discussion was, if you don't do anything, the child is going to die. If you give a patient a liver at this stage, the graft might be lost because of ongoing hypoxia. And what we wanted to do was to bridge this patient to transplantation. It was a very difficult decision for the team, but we started ECMO pre-transplant, continued the ECMO intra-transplant, and provided ECMO post-transplant as well. You can see here, this is the ECMO cannula, and within a few hours, we saw that hemodynamically the patient became stable. The transplant was performed under ECMO, and immediately we saw that the condition became better. These are the X-rays which were performed serially after bronchoscopies, and this is the X-ray just immediately pre-extubation. Patient came off ECMO within 8 days. We took the fluid off, we closed the abdomen. The child was neurologically intact, and the child was eating, drinking. Now, what I'm not trying to preach here is that ECMO is the solution for every acute liver failure. What I'm trying to talk here is that probably it is time for us to change the paradigm regarding what are the transplantation criteria, or rather, when is a patient deemed untransplantable? Because previously we used to say multi-system organ failure for more than 7 days is a contraindication for transplantation, but perhaps we have actually come off that criteria long back. So let's talk about etiologies. We talked about the spontaneous recovery in my previous slide, where I said more and more patients are recovering spontaneously. And if you look at the etiologies, they are varied from infective to toxic to metabolic to genetic and autoimmune. And this is the data from King's PICU, looking at about 11, 12 years of data. And you can see here, despite us doing all the fancy investigations, about 50% of our patients still do not have a diagnosis. It's called indeterminate or non-A to non-E hepatitis. And the next slide, you will see it's not only different, it's different in different age groups as well. If you look at our newborns, the most common etiology is neonatal hemochromatosis. If you look at our patients in between, you will see that most of the patients are either autoimmune or drug-induced. But if you go to adolescents, majority of our patients are drug-induced. So you cannot compare it with adults, where there is probably most common etiology is drug-induced. In children, it's different in different age groups, which will dictate what therapy. And this is exactly you see here, that if you look at paracetamol toxicity, for example, majority of our patients are getting, they're able to do well without transplant, just with spontaneous recovery and with our medical management. But if you look at patients with indeterminate etiology or with hepatitis B, the chance of spontaneous survival is only 21 to 22%. So knowing the etiology is important, because A, you can direct your therapy, and B, you know, is your child going to need a transplantation, or is your child going to spontaneously recover? So what are the investigations we do? We make sure we send investigations for infectious, drug-induced, metabolic, mitochondrial, all the components. But as I said, the main problem is in children, a lot of our patients still do not get a diagnosis. And what people are trying to focus as a research is, can we reduce this gap from what we have at 50%? And the recent literature suggests that they have been able to have this gap to 35 to 40%. And that is where our focus of research is, because it has got implications not only for that particular patient. For example, for neonatal hemochromatosis, you have got implications for future pregnancy. Knowing a mitochondrial disease, you know that these children have got neurologic involvement. And if you're talking about recurrent acute liver failures, auxiliary transplantation will be wrong in these patients. And as I said, for indeterminate etiology, you probably would list these patients as soon as possible rather than waiting for spontaneous recovery. As I said, etiology and treatment go hand in hand. If you've got herpes, you start acyclovir. If you've got paracetamol, you start N-acetylcysteine. The main aim is to prevent further toxic injury from whatever we are doing. The supportive treatment, very important, as Ajay mentioned in his cardiac talk, to make sure you make an early referral and liaise with your liver specialist. Maintain your glucose, avoid hypoglycemia, but please, 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 not at the cost of your sodium. Do not just give them 5 or 10% glucose, because hyponatremia, as I will show you later, is a bad prognostic sign. So we start all our patients on 10% plus normal saline, and if the need be, increase the concentration of glucose, but make sure the electrolytes are given. All our patients, whether they are paracetamol or non-paracetamol, they go on to 100 milligram per kilo per day of N-acetylcysteine. And this is a classic referral which sometimes people make. This is acute liver failure, renal function slight deterioration, sodium of 124, needs 5% dextrose because it's liver failure. So please be aware of hyponatremia, be aware of hypotension, and treat it accordingly. My colleague has already covered the transport considerations, but in acute liver failure, you can have 3 different kinds of transports you might be asked to do. One is a stable child who's just got raised INR and liver enzymes. That could be probably a ward transfer. A second, and I would say the most challenging transfer, is a child with acute liver failure, but fluctuating level of consciousness. And I think it is this child which gives you the most trouble to say, should I be intubating this child for transfer, or should I transfer the patient in a state the child is in, with obvious risk that you might have to intubate a child in the middle of a transfer. And of course, the third category is when you've got an unstable child with multi-organ system failure. What is the important decision making? As I said, intubate or not? What is the cardiovascular stability? Should I be doing the invasive procedures at the local hospital, or should I scoop and run? Should I be giving blood products? Should I be waiting and bring them with me? And should I start neuroprotecting the child at the local hospital? So this is the Children's Acute Transport Service where Phil works, and this is what we say early liaison with the liver intensive care teams at the receiving acute liver failure center. Once a patient comes to intensivist, what's our role? Our role is that with the help of a hepatologist, we need to determine what is the underlying etiology of acute liver failure. We need to recognize that acute liver failure may be precipitating the multisystem organ failure. We need to identify the patient with the help of our MDT team who would benefit from transplantation, and determine when is a child actually stable for surgery. We need to recognize that when the child is too ill, and of course, skilled postoperative management is crucial to successful survival of these patients. So this is what the acute liver failure protocol looks like. You can see here, this is our investigations, our general measures. We talk about cardiovascular, we talk about respiratory, but you can see here is our criteria. When do we refer a patient to critical care? That's very important for the ward. And then we talk about dialysis, we talk about nutrition, and we talk about coagulation. And our next A4 talks about exclusively about neurocritical care, neuroprotection, and neuromonitoring. How do you do that in patients with acute liver failure? Now, this is something I would want to stress on, because a very common myth, and the myth is the INR is high, this patient is going to bleed. So we need to give blood products to this child, whether it's FFP or whether it's platelets, whether it's cryoprecipitate. So if you look at this, acute liver failure, a liver is a factory which is going to manufacture both your procoagulant factors and your anticoagulant factors. In acute liver failure, both your pro and your anticoagulation factors are decreased, which means you've got a rebalanced hemostasis. And if you look at this, these are patients with acute liver failure. These are the controls. In patients with acute liver failure, your endogenous thrombin generation potential is sky high, which means that these patients are prothrombotic. So acute liver failure patients do not bleed spontaneously. So please do not give FFP just because the INR is high, because A, the patient doesn't need it, it's not going to bleed, but B, very importantly, INR is taken as a transplantation criteria. And if you give FFP, you're taking away a vital monitoring sign from a clinician and cause fluid overload as a third side effect. So please do not give blood products if a child is not bleeding. So this is what we say for coagulation. Do not correct coagulopathy unless you're doing an invasive procedure or the patient is actively bleeding. A number of these patients can have thrombocytopenia if the patients are septic or are in DIC. Infectious complications, very important, and we always say start prophylactic antibiotics and antifungals when you get these patients. You can see here, when you have got infectious complications, whether you get a transplant or don't get a transplantation, your survival decreases if you have got infectious complications. Let's talk about why patients with acute liver failure die. So historically, it used to be cerebral edema and intracranial hypertension of hepatic encephalopathy, followed by sepsis with multi-organ failure. And what people have found is that ammonia is the first molecule which was identified as a causal agent as well as a treatment point for hepatic encephalopathy. You see here, if you compare different cohorts of liver patients, but if you have patients with acute liver failure whose ICP is high, you see that the ammonia is more than 300 in these patients. And if you look at this human evidence from King's, looking at 165 patients with different kinds of acute liver failure etiologies, and patients who had ammonia more than 100, they had a 70% chance of getting encephalopathy. And if you've got an ammonia more than 200, there's a chance of intracranial hypertension of more than 90%. So it's not only high ammonia at presentation, it's a persistent high ammonia at 48 hours, which dictates the prognosis of this patient. So hyperammonemia, as well as persistent higher ammonia at 48 hours is bad. This is how ammonia causes damage. The ammonia normally comes from the gut to the liver. The liver detoxifies ammonia into urea, but when the liver is not functioning, this doesn't take place. So there's hyperammonemia in the blood. It goes to the liver, the glutamine is made, and the glutamine then enters into the brain cells. It's osmotically active and causes astrocytic swelling, leading to cytotoxic cerebral edema. Hyponatremia, as I mentioned before, potentiates the effect of ammonia on the brain through the same osmolar effects. Again, the water goes into the cells, and you can see here, if you've got hyponatremia, you've got almost 11 times more chance that you will get hepatic encephalopathy. And you can see here, if the ammonia is less than 135, there is a higher chance of getting hepatic encephalopathy. The third important point is lactate clearance. If your liver is not able to clear lactate, as you saw in our patient, that is a bad prognostic sign. So a combination of hyperammonemia and persistent hyperammonemia, hyponatremia, and decreased lactate clearance are bad prognostic sign for a patient with acute liver failure. Now, what has changed our understanding is the concept of systemic inflammation. Inflammation in a patient with acute liver failure, you see here, when the cells are dying, you've got the DAMPs, you've got the PAMPs, and you kind of trigger your monocyte and your neutrophil activation. They become pro-inflammatory, and there's a lot of pro-inflammatory macrophages which are released. You've got cytokines which are released and absolutely cause havoc in a patient who's got acute liver failure. So in an acute liver failure, there's a perfect setting of multi-organ failure because of this inflammation and because of this cytokine storm. You can see here where it's coagulopathy, it's hepatorenal, it's immune dysregulation, everything goes into disarray, and a patient with acute liver failure does not remain only liver failure, it becomes multi-organ failure. So why do patients die? In today's day and age, it is sepsis, multi-system organ failure, including cardiovascular failure, and as you see here, systemic inflammation with increased mortality and the role of immune modulation. And third is your cerebral edema and raised intracranial pressure. This is again coming back to the survival or the outcomes graph I showed you. It is here when the patient's liver function is rapidly falling and patients slipping into multi-organ failure, there is a role of extracorporeal liver assist devices. And why do we use them? Because by using them, we will be able to bring your ammonias down. You should be able to control your sepsis as your immune modulation, fluid overload, and AKI, and very importantly, be able to control your inflammation. So what we are trying to achieve here is a conducive environment, A, for liver regeneration, and B, if we know that a child is going to get a liver transplantation, we want to hand over the patient to our surgeons in a pristine condition. So what are these liver support devices? You can see the artificial liver support and bioartificial, but I would be concentrating is the artificial ones where we talk about continuous dialysis, and we talk about plasma exchange. When do we start these patients on continuous dialysis? If you look at this, this is a slide from the prospective pediatric dialysis registry, where you see these patients were put on continuous dialysis for various reasons, whether it's cardiac, it's renal, it's BMT, it's whatever, and the overall survival was 58%. But when you put these patients on to dialysis for liver disease, your survival drops to 30%. So the question is, are these patients too sick by the time we enter, or is CRRT actually causing a problem? So we organized an international consensus meeting on acute liver failure at King's in 2012. We wanted to thrash out a protocol which tells us, or at least guides us, when do you start these therapies, how do you start these therapies, and what is in store for the future. So what we say at King's is, in addition to your renal indications, you have got your extra renal indications, your liver indications, hyperammonemia more than 150 and not getting controlled, or an absolute value of more than 200, or hepatic encephalopathy grade 3, grade 4. So what we say is early for hyperammonemia, early for fluid control, early for nutrition. Then people ask, do we use high volume hemofiltration, high volume dialysis in these patients? The standard recommendation is 30 to 40 according to Claudio Ronco's paper, but we at King's compared 35 mils per kilo per hour with 90 mils per kilo per hour. You can see that with increasing dose of the ultrafiltration rate, your ammonia clearance is getting better, which means that higher the dose, more ammonia you can clear. So we at King's always start at 60 mils per kilo per hour, and then sequentially go up if our ammonia is not getting controlled. Then we wanted to know at King's, what is the effect of CRRT on outcomes in pediatric acute liver failure? And we looked at those patients who underwent CRRT. We looked at their survival to hospital discharge with or without liver transplant, and we looked at various biochemical parameters as well. And the striking feature was that of the 45 patients who underwent CRRT, we were able to delist 16% of our patients, even when they were really sick. They were listed for transplantation and we were waiting for a liver. We actually were able to delist them because of what interventions we were doing. Now, what was striking in our paper was the difference between survivors and non-survivors. If you look at survivors, your ammonia is nicely coming down. Whereas in non-survivors, you see that either it's not coming down or it's going up. So inability to bring your ammonia down despite starting them on dialysis at 48 hours is a bad prognostic sign. Then we looked at the difference between prior to 2011, when we were very conservative in our dialysis indications, just starting them for AKI and for fluid overload or for decreased urine output, to now moving proactively to starting them for ammonia and hepatic encephalopathy. You see that in the first 14 days, there is a visible benefit. This is the time when we are either looking for a liver or we are wanting the patient to spontaneously regenerate. So what we concluded was that if we institute high volume CRRT early, within the first 48 hours, and are able to bring our ammonias down, that helps by decreasing the brain swelling, that helps by improving your hemodynamics and improving the fluid overload and AKI. The next question what gets asked is, now these patients are having high INRs, should you be anticoagulating these patients actively? And if yes, what are our options? No anticoagulation is not an option because these patients, as I mentioned before, are prothrombotic. And if you let them have no anticoagulation, the circuits are going to go down again and again and again. And you cannot afford the circuits to clot, especially in acute liver failure, because your dialysis machine is not only working to remove the bad products, it's also helping as a brain protective mechanism. You don't want that. So either you use low dose heparin, which we don't. We are an exclusively prostacyclin using unit, and people are scared of citrate because people feel that citrate gets excreted through the liver and therefore can cause citrate toxicity. And sometimes when the patients clot their circuits, very frequently we combine heparin and prostacyclin. You can see here a three-way tap, heparin going here, prostacyclin going here, and we maintain the patency of the circuit as a priority. So what does the European recommendation for adults recommend? They recommend early institution of renal replacement therapy for hyperammonemia, control of hyponatremia, and they feel that the anticoagulation is still a debate. Unfortunately, no pediatric recommendations yet. Now, in addition to continuous dialysis, we need a extracorporeal device which does both the synthetic function of the liver and the excretory function of the liver, and therapeutic plasma exchange is one. When you're removing the plasma and freezing it, you're doing the excretory function of the liver. And when you're giving the FFP back to the patient, you're doing the synthetic function of the liver. And this is the same cartoon once you start high volume hemofiltration and high volume plasma exchange, you dampen the whole immune cascade which had got triggered in acute liver failure. You convert your pro-inflammatory neutrophils and monocytes down, and that is able to maintain your immunomodulation. And this is an evidence in infants from Japan, where patients less than 1 year of age, where the survival rates are actually quite low, they combined high volume hemofiltration with plasma exchange, and their survival was 88%, which is quite a high survival as compared to other series in the same age group. How do we neuromonitor them? We do it non-invasively. We use transcranial Dopplers. We have reverse jugular venous saturations in most of our patients, and we have near-infrared spectroscopy in these patients. So this was our review with Professor Rob Chaska. We looked at different non-invasive methods of neuromonitoring. We say tympanic membrane displacement and optic nerve sheath, which are used in various centers, but not at King's. But this is a 3 we do: transcranial Dopplers, reverse jugular venous, and near-infrared spectroscopy. How do you neuroprotect them? It is all the principles almost remain the same for traumatic brain injury, but what we need to understand is the difference between hyperemia and ischemia. You might get decreased blood flow, or you might get really increased blood flow, as was happening in our patient, which I showed, where because of cytokine storm, the blood-brain barrier is not there, and you actually provide a lot of blood flow to the brain. What we try to avoid is 4 H's: hypotension, hypercapnia, hypoglycemia, and hyperthermia. And when we have thrown everything at the patient, i.e. barbiturate coma, therapeutic hypothermia, what we ask then is call our surgeons and ask them, can you please remove the liver? And this is the temporary anhepatic phase, where the liver is now out of the body. And the reason that the anhepatic stage helps is because if you do that, the cytokine storm, the source of cytokine storm, is removed. But again here, your dialysis becomes very, very important, because your dialysis not only works as a kidney device, it also works now as a liver support device, because the liver is out of your body. So this is what our neuromonitoring and neurocritical care protocol looks like. You see here, this is how we neuromonitor our patients. And this is depending upon our reverse jugular venous saturations, how we maintain, when do we put our ICP bolt, and the upper portion talks about how do we neuroprotect them by various medical interventions. So as an acute liver failure package, we intubate, ventilate them, we put a central line in, we put an arterial line, put a reverse jugular venous, start them on non-invasive methods of neuromonitoring, put a VASCAT in for continuous dialysis. And if any of the neuromonitoring devices are showing problems consistently, that might be an indication to consider invasive intracranial bolt. Something which is very interesting, the next few slides probably might not be practiced throughout the world. What we do is we do something known as auxiliary transplant, where we leave a portion of the patient's necrotic liver in his body and then give a part of a donor liver in the body. And what we are trying to achieve here is, with the time, this native liver will regenerate. And when we withdraw the immunosuppression, this is gonna regress. And within about a couple of years, you will be completely off neurosuppression. And you can see here, they are dissecting the liver. One portion will be left behind, other portion taken out, and a donor liver fitted in. And this is what happens. This is 10 days after your auxiliary transplant. You can see here, this is the donor liver. At 7 months, you see that the portion of the liver which was left behind is starting to regenerate. And at about 1 year, you can see that this is the patient's native liver that is bright, but the liver which was given to the patient is now completely regressed, because we have taken off immunosuppression. This is shown here as well, time 0. This is completely fibrotic. At 6 months, you can see that the hepatocytes have started to regenerate, and at 18 months, there is no fibrosis at all. This is the concept of auxiliary liver transplantation. Coming to a very novel technique at King's, hepatocyte transplant is not a liver, it's just the liver cells which are used, and they perform the synthetic and detoxification function. There's no immunosuppression. You can see here, through the portal vein, the hepatocytes are getting implanted into the liver. They start performing the detoxification and synthetic function of the liver. But if your ductus venosus is still open and you don't have access in a newborn in neonatal acute liver failure to this, what we then do is we coat these liver cells in alginate and make beads out of them, and we put them into the peritoneum. You can see here a needle going in, and you get the hepatocytes within the peritoneal cavity into the abdomen. And in our experience, of the 8 newborns we gave hepatocyte transplant, 4 were alive without liver transplant. It means spontaneous recovery. 3 had liver transplant and 1 we withdrew care. So basically 50% of patients just with hepatocytes were able to have native liver survival. So my last slide, we have seen here that your native spontaneous recovery is going up. So this is the major paradigm shift in the concept of acute liver failure. It's a dreaded complication. There's a high mortality without transplant. But if you have access to liver transplant center, you start your therapies as soon as possible, depending upon etiology. You neuromonitor them, you neuroprotect them. If you've got high volume dialysis going on and you control your sepsis, you should be able to achieve spontaneous liver recovery, depending upon what etiology is causing acute liver failure. With that, I thank you for your attention. And as I said, it's all about the team. It's about the liver team, the intensive care, the transplant surgeons, the transplant coordinators, all working together. And I'm very lucky to be working with a very good team. And I've got one of my colleagues, Phil Knight, on the call here. So thank you, everyone.
Thank you, dear professor, for this amazing lecture. I see a lot of questions in the chat section. I myself had a lot of questions, but sadly we're a bit short of time. So because we have to start our next sessions in a few minutes, so we cannot get to the questions in the chat section. But I can't thank you enough, you and your dear colleagues who've accepted our invitation and whom have joined us during this session. This was such an honor for me myself to be here and to learn from all of you guys. And this was really inspiring. So thank you for accepting our invitation again. And I wanted to ask if it's possible for all of our lecturers to open their video. So our guests are more than welcome to open their video as well, to take a group photo as a as a I don't know, memorial picture. So hi, Dr. Money. Hi. Okay, so I see that he is the lecturer for our next session. So let me, just a minute. Let me take a good photo. I have to spotlight everyone. Just give me a few seconds. It has to be perfect. This has to be written in history. Okay. Ooh, my dear friend Mariam. Okay. So, okay, I am going to take a picture right now. And everyone, please smile. Oh, I see another one. Wait a minute. I'm sorry. Oh my God. I'm really sorry. Oh my God. I think I missed. Sorry. Please stay and keep smiling, please. I'm begging you guys. Could you guys help me add the spotlight for everyone? I am really sorry, but this is an exciting photo, which has to be perfect. Okay, I think we are good to go. And please, everyone, smile. 1, 2, and 3. Amazing. I can thank you, and I will send you the pictures.
Thank you
Have
very
a great
much.
day.
Thank
you.
Thank you.
Bye, everyone.
Bye.
Bye-bye.
Bye.
Thank you.
Oh,
Dr. Akash, Dr. Ajay, and all the speakers. Sorry, I was busy with another session, but you know how much we are thankful for your time and for your knowledge. Thank you very much for sharing your knowledge with us. You are close friends to our university and to our colleagues. Thank you very much. Thank you very much.
Thank you.
Bye-bye.
Bye-bye.
Have a nice day.
bye.
Bye.
So for all of our audiences, we will start our next session. It is also going to be about critical patients and also ICU management. So we will start in 5 minutes. Sorry for the delay, especially sorry, Dr. Mani, for this delayed having start, but we will start in 5 minutes.